So if someone measures their BP in whatever setting and whatever time of day and it is above 180 by 120, what is the immediate step they must take?
Go to a hospital, get admitted. That is the first thing.
What percentage of kidney disease is related to high BP?
30 to 40%. So the biggest drawback of having a kidney disease is kidneys are pain insensitive. You don't get any specific symptoms of kidney disease.
So what is an early sign of kidney damage?
Proteinuria. Leakage of protein in urine, the cheapest and the easiest test to do. Pass urine, painless, one dipstick, 50 rupee cost.
These new drugs, GLP-1s, are they kidney protectant? Do they impact the kidneys adversely, positively?
Some of the only drugs which actually show improvement or protection for the kidneys are the GLP-1 analogs and drugs which are SGLT2 inhibitors. They are fantastic for renal protection.
Hello everyone, this is Khushbu Agarwal, founder at Zyla Health. Welcome to the 24th episode of Conversations with Zyla. Today I have the pleasure to host Dr. Debabrata Mukherjee, Senior Director Nephrology at Medanta. Sir, thank you so much for joining us today.
Thank you, Khushbu. It's a pleasure to be here with you and your team.
Thank you, sir. So, Dr. Mukherjee is a very well-known nephrologist. He has spent 3 decades at the forefront of kidney care. Having spent majority of his time at the armed forces, he now leads nephrology at Medanta and specializes in very advanced treatments as well as early diagnosis. Dr. Mukherjee was the recipient of the prestigious Atmanirbhar Bharat Award in 2025. What a pleasure to know that, Dr. Mukherjee, and such a delight to be learning from you today.
Thank you so much, Khushbu.
Great. So, Dr. Mukherjee, before we start, we always like to cover about your practice, and you have an amazing busy practice at Medanta. So, would love to understand, given today's topic around kidney care and also related to World Hypertension Day, given high BP is the leading cause of kidney damage, I wanted to understand what sort of patients walk into your practice most often these days, and if you can add some color around the gender diversity, age diversity, that will be great.
Okay, thank you, Khushbu. As you correctly mentioned, my tertiary specialty is nephrology and kidney transplant, but I'm basically a physician, a specialist in internal medicine. So in our practice, we deal not only with patients with kidney failure, but we also have to treat the conditions leading to kidney failure. And primary amongst them is hypertension, diabetes, heart disease, atherosclerotic vascular diseases, CVAs, cancers, which ultimately lead to failure of the kidney, right? Now, the days where we used to think that hypertension was a very niche illness amongst the rich, and that too in their 40s or 50s or a corporate, that's no longer true. Over last 3 or 4 decades, we are seeing younger and younger people getting chronic lifestyle diseases. Even the misconception that India doesn't have a chronic lifestyle disease problem. We are a country with problems of diarrhea, dysentery, typhoid, malaria, tuberculosis, but that's not really true. We are having young people, 22, 23, 24 years old, athletes who are dying on the treadmill, who are having heart attacks, who are having renal failure, who are having chronic diseases. So the spectrum of diseases is changing. We are coming more and more close to the Western spectrum of diseases. You get children with hypertension, which is ironical. Till date, we never used to. That's why the school health programs are picking it up. We are having youngsters. We are having old age people. Why? Because India did not have very much of an old population. Our lifespan wasn't very great till few decades back, but now we have people in the 80s, 90s.
Right.
So they are coming with heart disease, with hypertension, with kidney failure. So more and more the bandwidth across the ages who are getting chronic diseases becoming longer and longer.
Right. And some statistics there, Dr. Mukherjee, like what percentage of your practice would be who come up with a kidney disease at whatever stage? What percentage would be male versus female? What percentage would be adolescents or kids today?
Okay, I think women are a blessed group.
Hmm.
They do not, for some reason, have this much of chronic ailments.
Till we hit
Premenopausal,
menopause, yes.
premenopausal. Postmenopausal, their risk strata becomes the same.
Right.
But fortunately, for whatever be the reason, uh, habituations are lesser in Indian women.
Hmm.
Smoking, drinking,
Right.
drug abuse is not really very prevalent in the, it's not non-existent, but it's not very prevalent. So stress,
Hmm.
so those are not very prevalent in women. So probably to some extent they are protected against chronic disease, not 100%. So I would say in the renal failure category, 30 to 35% of the practice would be women coming with renal failure. Now, how much of that demographic is because the women don't come forward for health checkup,
Okay.
or the families don't spend so much on their treatment is a different question altogether. But overall, I would say around 30 to 40% are women
In the renal failure sort of
in the
segment.
failure,
And
where people have got kidney failure.
got it.
Amongst the diabetics, I would say they are equal. Hypertension, male prevalence 60-40, I would say.
Got it.
Children, if you have a niche practice which looks into children with kidney diseases, we do have a significant number. But the types of kidney diseases for children are a little different. Hypertension in the teenage group is still seen, but not very prevalent, 10-20%, but it is there.
10-20% of incidence in the teenage population
Yes.
of hypertension.
Yes.
And this is something recent that you're seeing.
I would say over the last decade or two.
Right. And what is leading to all of these shifts, Dr. Mukherjee?
Smoking,
Smoking.
stress,
Right.
and lack of physical activity,
Mm-hmm.
unhealthy lifestyles, bad diet.
Bad diet.
When we take the dietary habits of the Western countries, pastries and burgers and pizzas and cheese, which are not our natural diet, we take that free gift of those diseases also. Obesity.
Mm-hmm.
You see, obesity is highly prevalent nowadays in the teenage group,
Mm-hmm.
both among girls and boys.
It's true.
Uh, Artificial supplement fads, dietary protein supplements, creatinine supplements. So all of this in some way contribute to chronic diseases, kidney diseases, hypertension. Salt, pre-processed foods are very high in salt.
Mm-hmm.
So hypertension does come up. Youngsters working are and getting very good salaries. So smoking and alcohol both are much more easily available and affordable.
Right. So, Dr. Mukherjee, I'd like to cover a few aspects that you said in your answer and pearls of wisdom there. You mentioned smoking and alcohol in the same breath, right? So, we do understand smoking, of course, leads to high BP, and BP leads to kidney damage over time. But does alcohol also have a direct correlation?
Alcohol does worsen kidney failure. Alcohol by itself per se does not cause renal failure.
Right.
But the environment in which alcohol is consumed and the circumstances leading to high intake of processed foods, chips,
Okay.
salt, that does contribute to it.
So, that entire lifestyle is
Correct.
an ecosystem.
So it's not a specific direct causal correlation. It's like environmental toxins and pollutions. They may not directly affect, but they do indirectly affect.
Got it. And in your answer, you also mentioned protein intake, processed protein supplements as one of the reasons for kidney impact or high BP. Can you elaborate upon that? Because a lot of our users and patients we have seen being even prescribed those.
Yeah. There are two kinds of protein supplements. One is the pharmaceutical grade protein, which you give to patients who are admitted. You know, a edentulous patient or a patient who cannot take adequate nutritional supplementation. The second type of protein supplement is what is a food additive, right? They don't come under the pharmaceutical grade. the gym protein supplements. Now, what happens is when you take a very high protein load. Now, to example, suppose I want to consume a lot of protein, say 2 to 3 grams per kg.
Right.
I want to build a body. If I have to eat mutton, chicken, or fish, I have to consume a huge quantity, correct? To achieve that kind of protein
Correct.
intake,
Which is difficult.
which is difficult. So, that nature itself stops you from taking too much. While I can take 3 glasses of protein shake without any problem,
Right.
right? So the amount of protein load overloads the kidney, because finally it's the kidney which has to deal with the waste and metabolites. So it stresses out your kidney. Second problem is the artificial additives that are added. Any protein which you leave outside is going to spoil. Your fish spoils, your egg spoils, your paneer
Correct.
spoils.
Right.
Why doesn't your powder spoil? Because they have stabilizers. So those chemicals, if they are not well regulated, can cause kidney damage. They are toxins. So it's a combination of protein supplements in overdose, inadequate hydration, combined with possibly not very good quality stabilizers, which can cause. We see young kids who want to build body. Everyone wants to look like Hrithik Roshan and Arnold Schwarzenegger, but they don't want to put in the time and the effort for it. They want instant results.
Right.
And this is what is causing problems. We are seeing young kids coming with raised creatinine or raised liver enzymes.
Should these protein powders even be OTC products, Dr. Mukherjee? Actually, they should be more prescribed, right? Because now any brand can launch any protein supplement today.
Exactly, because this is not regulated by the under the Drug Act. It's
Right.
taken as a food supplement if it is regulated by FSSI. So anybody can make anything, claim anything on the brand, whey protein, soy protein, and market it. And young minds are very impressionable. So the person who exerts a lot of, I would say, influence on these people are their trainers. The gym trainers.
Trainers, Instagram influencers.
Instagrams, influencers who say, look, you take this and you will have a body in no time. You look great.
And beyond even, taking a product, it's also about what is written on the product may not be absolutely transparent, is what you're saying.
Absolutely.
Right. And just elaborating upon this protein aspect, Dr. Mukherjee, very important one for our younger audience also. There are a lot of these products which are now supplemented, like breads, yogurts, right? They're supplemented with protein. So are they also harmful? How does one choose what is healthy, not healthy? Because you can't make everything at home, possibly.
Yeah, you can't. So one line which I liked in one ad which I saw. If nature didn't make it, don't take it. I really like that. But cooking a healthy meal requires a tremendous amount of effort and time. So sometimes it's just not possible always, if you have a very busy schedule, both couples are working, to be able to make everything from scratch. But definitely we can choose the quality of the ingredients we use and take it. I'm very chary about things saying fortified with proteins. Proteins get denatured in high heat. So if you're baking a bread, how will your protein remain in intact form?
Right.
So if you're having bread, have bread. If you're having proteins, have egg, fish, or similar proteins up.
Right. Don't confuse it all.
And it's not very difficult to boil 2 eggs and have it.
Right. So now, the golden question, given we spoke so much about protein, what is the adequate protein amount? Is it a hype that you need 1 gram per body kg weight, or is it scientifically proven?
That's actually a fantastic question. See, why should we take protein at all? The body which you're seeing today is not the body which you had 6 months back.
Right.
What I meant by this is, the body is in a constant state of repair. Your hair falls off, it makes new hair. It makes new skin, new cell linings, right? Your white blood cells, your antibodies. So the body is like a factory which is constantly churning. And things which are not, it's like old clothes, which are no longer repairable, the body throws out. For that, you need proteins. Every cell is made of protein. Antibodies are made of protein. Now your protein requirement changes as per your age. When you're young, when you're a kid, you're in a positive anabolic stage. You're growing, right? Your body needs more protein to get taller,
Absolutely.
to get great hair, good skin, good eyesight. When you're in your 30s and 40s, your anabolism and catabolism is maintained. Your expense and intake is more or less balanced out by the body. When you're older, your catabolism or breakdown is far more than your anabolism. That's why you get wrinkled skin, loss of hair, balding, poor eyesight, loss of muscle mass. Now, this gets compounded by any disease conditions, diabetes, hypertension, kidney disease. And you're not able to absorb food very well. What you could eat in your 20s is not what you can eat in your 50s, right? You may be able to eat a steak in your 20s. You can't do it in your 50s and 60s. So you need high quality protein, better quality, and in smaller quantities. The average protein requirement, again, average is 1 to 2 grams per kg body weight. This is the average nutritional requirement. There are special conditions under which it may be little lesser or more, but more or less that comes to 60 to 100 grams of proteins a day.
And that, I think, is the tricky part in India specifically, where we are a vegetarian household.
Again, lovely point. Yes, you're right. But it's not just vegetarians. If you see Indians, a non-vegetarian also has non-vegetarian maybe twice a week, no matter how rich you are. We don't get up in the morning and have pork and a beef steak in the afternoon and a fish fillet and chicken at night, even a hardcore non-vegetarian.
But I think vegetarians have it a better way.
Maybe one egg a day or two. So little better, but not that much. Even in vegetarian options, you get excellent vegetarian protein options. Tofu is one of the best sources of protein. The biological quality of protein of tofu or soya paneer is the same as that of an egg. Other than that, it's only paneer. Dals are incomplete protein. So if you don't even have paneer and tofu, then you're not going to get vegetarian proteins at all. So this is the reason Indians look scrawny but with large pot bellies. We have poor muscle mass, poor proteins, but high and diet which is very rich in carbohydrates. So we need to change the spectrum and take better quality protein, especially people who have some chronic disease.
Right. And I think tofu is not a household name in India.
We used to have a household name. It used to be called Nutri Nuggets. And kids used to love it. For some reason, people have stopped eating it, but it is there.
Right. Very, very interesting. So, Dr. Mukherjee, thank you so much for shedding light on the causes and, we deep dive into the protein aspect. You mentioned some lifestyle aspects like smoking, alcohol intake, diet, protein intake, right? And in the beginning, you had mentioned a line which stuck with me, where you mentioned women are less prone to kidney disease, probably, and you see lesser of them in the practice. You did mention stress as a factor, and you said that women are less prone to stress, which is little counterintuitive to my last, we did a podcast a couple of months back with a leading psychiatrist from Artemis, and he said twice the number of women come to his practice than men, right? Given the situations of mental health. So what is your take on that?
No, I don't think I conveyed myself very well. I didn't say they are less prone to stress. Women deal with stress better.
Yes.
Because they are more communicative. They don't internalize. They are better at multitasking, building friends network. They are far better at it.
Yeah, yes. He said the same inside, correct.
Yeah, so if you see, men deal with stress very poorly.
You don't talk.
You don't talk. That's why you'll find dementia cases are far less in women than in men overall. because they communicate well, they talk, they share. That's what I meant.
Right. So hence you're saying that the incidence of BP, which is stress led, is also more in men
No,
probably.
physiologically also, women are, while in their reproductive age group, the hormones protect women from many of these conditions. It's not 100% protection.
Of
It's not
course.
that they are immune to it.
Of course. If they smoke, they will get it.
Yeah, if they smoke, if they drink, or if their diet is not good, they will have it. But overall, the protection is much more.
Right. Got it. So, Dr. Mukherjee, now just talking about this new age trend of elevated BP in the young folks. Imagine 25 to early 40s. And, in corporate India, everyone talks about work stress and deadlines. And, maybe someone has a difficult team or difficult boss. And, they say that's what led to my poor health. But what is really the common rise in, say, a corporate setup beyond lifestyle that you have seen?
So, this, what I'm telling you, is purely my subjective
Yes.
opinion, okay? Because this is very difficult to answer scientifically.
Mm-hmm.
I don't think job by itself is always stressful. Jobs were always there. People had to. I mean, the job nature may have changed. But bosses, even medieval time, the peasants would not have been very happy with their landlords. Okay,
Right.
so that would be there. I think a lot of stress is a combination of multiple factors: home front, work front, money front, ambition. So I think all of it leads together to stress issues and a breakdown of social fabric, where you do not have large families to share with, large brothers and sisters combined,
Right. Friends.
friend circles, you get isolated. The people you meet are all in the same rat race as you. And what you forget is that even if you win the rat race, you're still a rat. So it's really not worth it.
Right.
So you realize these things probably much later, because when you're young, and that is the time you have to work hard and you have to grow, you have to get your promotions, get that corner office, get that Lexus. So,
Mm-hmm.
so I think it's a combination of
So
everything.
it's more of your mental state than surrounding
Yeah, you
you.
come back, your wife is also stressed because she's also working. Your parents are not in that same city, they are in a different city. They may be ill and you're not able to visit them. So
Right.
I think it all adds up.
Very, very well said, Dr. Mukherjee. Now, talking about high BP itself, what have you seen in terms of trends of undiagnosed BP, which is the biggest peril we deal with at Zyla, right? We see when we do a hypertension camp, 20% people will turn up with hypertension, right? And another 20% with pre-hypertension. And none of them knew, or maybe 5% of them knew. So, which age brackets do you see undiagnosed BP the most, Dr. Mukherjee?
20 to 40s maximum number, because that is the age group where we feel invulnerable. I'm healthy, I'm fit, I go for my run.
Hmm.
No, I can't be ill. That's a thing of old age. Not that it doesn't exist in their 40s and 50s, it does. But the undiagnosed spectrum is mainly in the early stages. What happens by the 40s and 50s is, by that time you start having organ system involvements. You start getting syncope, you get palpitations, or maybe blurring of vision, and then you go for a checkup and you come to know that, look, I've been having this for a long time.
Right. So there are no symptoms at all till what stage?
It depends on the condition you're talking
Hmm.
about. If we are talking about hypertension, unfortunately, the belief that hypertension causes headache, hypertension causes neck pain, is a big misconception. Hypertension is silent. Hypertension, when you go into what is called malignant hypertension, accelerated hypertension, BP has gone up to 200, you have had a bleed in the brain or something, then you get symptomatic. Most of hypertension is asymptomatic. Kidney disease, you may land up with a creatinine of 18 and still not be symptomatic.
Hmm.
Why? Because the symptoms are non-specific. You feel a bit tired. All of us feel tired some days.
Right.
You don't want to eat. So you feel यार कभी कभी ऐसा तो होता है ना, भूख नहीं लगती है.
Mm-hmm.
तो थोड़ा पैर सूजा, आज सुबह से खड़ा था तो पैर सूजा हुआ है. The symptoms are non-specific. And when the symptoms are non-specific, you tend to get diverted. Suppose you are having nausea and vomiting, you'll go to the gastro specialist. Or you're having giddiness or loss of concentration, you'll go to the neurologist. You get palpitation, you'll go to the cardiologist, because there is no specific symptom of kidney disease at all, except when you have stones and you have pain.
Mm-hmm.
So the biggest drawback of having a kidney disease is kidneys are pain insensitive. You don't get any specific symptoms of kidney disease.
Or they're the most resilient.
No, not resilient. It's just that the conditions keep getting compensated by the body's reserves.
Got it.
And you don't come to know till you have actually reached with the potassium of 7 and you reach the emergency.
Right. But Dr. Mukherjee, isn't it the case that whenever you visit any doctor, say in India, the first thing they'll measure is your weight and BP? I would say in 80-90% cases, right? And I'm assuming anyone, say above the age of 25-30, would end up going to a doctor, say in a city, at least once a year. So how come, this underdiagnosis still exists?
Okay. The lacunae to this is somebody going to the doctor. Nobody likes going to the doctor.
That is true.
And nobody likes going to the hospital. So they would much rather, if they have a problem, go to the nearest pharmacy. या सर दर्द हो रहा है, क्या ले लूं?
Another peril of our country, yes.
Yeah. So this is very common. It's across the board. They'll say, I'm having vomiting, क्या एक दवाई दे दो. Going to the doctor, getting an appointment, sitting there, waiting there, loss of one working day, having to take leave, that restricts you till you actually have a condition and you're compelled to go.
Right.
Second is, suppose you do go there, okay, and he says आपका BP 135 136 है, थोड़ा सा ज़्यादा है, बहुत ज़्यादा नहीं है, बीच बीच में आके चेक करवा लेना. 136 तो ठीक है यार, morning I went for my run so I have it. So next time you go is when your BP is 170.
Right.
We'll not go back.
Right, or you assume that you went to the hospital so you were stressed and hence the BP was
So
high.
the peril of a self-paid healthcare is this.
Right. Correct. No, so you're right. I think doctors in India are very, very good at diagnosis, but how many patients are actually ending up visiting them regularly?
And following up.
Following up. Correct. No, that's the main problem. Dr. Mukherjee, when we talk about this undiagnosed BP, do you see a different trend in a Tier 1 city like Gurugram, Bangalore, Bombay, vis-a-vis a Tier 2, Tier 3?
I have worked in a lot of Tier 2, Tier 3 cities, remote areas of Arunachal, Nagaland, Jammu Kashmir. I worked in Tier 1 cities, Bombay, Bangalore, Delhi, Calcutta. I would say overall the undiagnosed spectrum remains the same, but the causes are a little different. In the Tier 2 and remote areas, it is accessibility to healthcare which restricts you from going and getting a checkup. In a Tier 1 city, probably time and inclination is the one that restricts you. But overall, the spectrum more or less remains the same.
And even the root causes you think are similar?
The Tier 2, Tier 3 are catching up with the metros as the cause.
And I think in your experience in the armed forces, then you would have seen the people across the spectrum.
Yeah, we have seen across, but armed forces has certain peculiar scenarios. You work in high altitude. You have guys shooting at you, so it generally it tends to be a little
You
high
have been
stress.
in those action-packed sequences.
Yeah. So then remote areas, but the good part of the armed forces is that we provide healthcare not just to the serving population, but all the neighboring villages and the locals. So I would say the spectrum of undiagnosed cases is more or less the same.
Right, but they may be dealing with more communicable diseases still, right?
Yes, absolutely. The problems of malaria in the northeast, HIV, tuberculosis, cholera, dysentery, malnutrition is much, much higher
right
in the smaller areas.
So now, Dr. Mukherjee, given you practice nephrology and kidney care in your work at Medanta, BP being one of the top causes of kidney damage, what are the other comorbid conditions which accentuate this kidney damage along with high BP?
The the biggest contributor along with hypertension is diabetes.
Mm-hmm.
The next biggest contributor is obesity.
Okay.
So what we have, what is called a metabolic syndrome, dyslipidemias, high cholesterol, obesity, hypertension, and diabetes. They are the root cause of the major number of kidney diseases and liver diseases, not only in India, across the world.
Right. And talking about obesity as such, which is known to be the mother of all these diseases, now there's a lot of innovation in the space in terms of injectables, medicines for obesity. Have you seen people opting for those to treat this root cause itself?
Yes, in fact, there is a tremendous amount of interest, not so much generated by the medical profession, but a lot of celebrities who have managed to lose weight and are
Right.
looking great on
Mm-hmm.
TV or on the media. People are opting for it and it works. Only thing is, this is not a therapy that works in isolation. If you have not addressed the root causes of sedentary lifestyle, bad dietary choices, you tend to regain the weight the moment you stop the injections.
Right.
So it has to be a more holistic approach, something like what you people are doing.
Mm-hmm.
You know, giving lifestyle and healthcare advice which is comprehensive.
Got it. No, that is it has to be together and not in isolation.
Correct.
Very well said, Dr. Mukherjee. And do you think these new drugs, GLP-1s, because they talk of the town and we get a lot of queries around them also, are they kidney protectant? Do they impact the kidneys adversely, positively?
I'm very impressed you brought that point up. Yes, they are kidney protective. In fact, some of the only drugs which actually show improvement or protection for the kidneys are the GLP-1 analogs and drugs which are SGLT2 inhibitors. They are
Right.
fantastic for renal protection.
Hmm. So you see them being prescribed in your
Oh,
practice?
yes, we are using it very regularly, not only for weight loss, because these are primarily also drugs which I have used for
Diabetes,
diabetes.
yes.
So, when a patient comes with a kidney involvement and has a background of diabetes or a metabolic syndrome, these drugs are wonderful.
Right, because the first GLP-1 launched was liraglutide,
Absolutely.
and weight loss was a side effect.
Weight loss was a beneficial effect nobody
Right. I mean,
expected.
yes, it was still reported as an AE,
Yeah,
and then people, created drugs around that.
yeah.
So great to hear from a nephrologist that when taken in caution under medical device and in a holistic way with lifestyle, they can actually improve these comorbidities and also be kidney protective as such. Great. Now, in terms of hypertension itself, given we are, talking about World Hypertension Day also today, Dr. Mukherjee, the numbers are very confusing for people, right? As you rightly said, I go to a doctor, I get a BP of 135 by 90, and they'll be like, yeah, it's evening, you've been through work, this is normal, you should monitor it, right? That monitoring never happens, unfortunately. So, what is the right number for an isolated reading? At what number should I monitor? How frequently to actually say that this needs care?
Okay. The first part of blood pressure recording
Mm.
is the time of the blood pressure recording. The correct time is when you get up in the morning, before you have had your tea or coffee, sit down relaxed, take a sitting BP of one arm, stick to that arm, and that is your baseline recording. If you record BP after climbing the stairs or watching a movie or having a cup of coffee, you're going to get different readings.
Mm-hmm.
So, to diagnose hypertension, you should have at least two such readings abnormal spread over a period of time.
In the morning.
Yeah, correct. You can't diagnose by one reading.
Mm-hmm.
And the third part is it should be correctly measured. The cuff should be of the correct size. The cuff should be tied properly. A correct instrument should be used.
Mm-hmm.
At an average, a person should realize that if his BP is below 130 systolic more or less, he is okay. For the elderly group, I would say up to 140 would be okay. Anything above that, you should get it rechecked. Look for target organ damage. Look for proteins in your urine, whether your heart is showing thickness, which is called left ventricular hypertrophy, whether your eye vessels are showing hypertensive changes. So those need to be monitored. When you have an abnormal reading, you must keep checking it till you are very sure either it is abnormal and then take treatment, or it is normal and that was a false reading.
Right. And the evening reading is not required, you're saying, for
No,
this?
not really. Not for diagnosis or for monitoring purposes. There are certain specific conditions under which you have to take repeated readings. Some people have brittle hypertension. Some people have things called autonomic neuropathy, where you have very erratic blood pressure readings throughout the day. Under such circumstances, you can do it.
Got it. So now talking through a patient journey, someone records their BP twice and they, basis their age, get it in a state like, a 135 by 95, and they repeated it similar, and the doctor says that this classifies as hypertension. Now, at what numbers do I need to start taking medicines?
Okay, the first intervention in any such condition is lifestyle. If you're overweight, try and reduce weight. If you're diabetic, get under good control, right? Decrease your salt intake. Don't eliminate it, but decrease your salt intake, reduce your processed food intake, reduce soda and soft drink intake. And over a period of time, you may find that your blood pressure starts settling down in the early stages. And when you don't have a target organ damage. If you have a target organ damage and your BP is persistently high, you have to be on medication.
Right. So I'll just pause you there, Dr. Mukherjee. When you say target organ damage, given, we'll just convert it into layman terms for the audience. Your BP comes high, the doctor says this is hypertensive stage, right? Now I have to do some further testing, you're saying, to first figure out, has there been any damage in the body? Was it silently prevailing for a while? So what are those tests that I must do?
Okay. Blood pressure tends to directly damage certain organs.
Right.
One is the eye, where you start getting abnormal blood vessels, what is called hypertensive retinopathy. It's a very simple test. You just go to the ophthalmologist, they use a ophthalmoscope and have a look at it.
Right.
Second is it causes the heart muscle to thicken, what is called left ventricular hypertrophy. So you can diagnose that either with a echo or a ECG.
Okay.
And the third organ which gets affected is the kidney, where either you will have protein leaking from the urine or your creatinine going up, or maybe a combination of both. So all three target organs should be evaluated.
Got it. So basically, you're saying you do your echo test for the heart, you go to an ophthalmologist and get your eyes
Eye
checked,
tested.
and then you do a blood kidney test and a urine test to see any protein leakage in your urine.
Absolutely.
Now, given two scenarios, one scenario is all came normal, right? And I think there'll be some age caveats also here. But all came normal vis-a-vis some tests as abnormal. What are usually the decision points in care?
So if you have hypertension with no target organ damage, you're in a very good place. Get your BP under control, you may never end up with a target organ
start
damage.
with lifestyle if it's not.
Lifestyle is simultaneous.
Okay.
Right. That is an inevitable component of everything, right? You can't just, you have a BP of 160, you can't just leave it at lifestyle.
Got it.
So your lifestyle changes definitely are very important. And you start your medication, get your blood pressure under control. If you have target organ damage, then the choice of medication may vary. Like if you have kidney disease, you have specific drugs which are better for use. If you have heart involvement, there may be different drugs which are used as the first line for treatment of hypertension.
Right. So it's clear that if you have high BP, anything above 130 by 90, and there's target organ damage, then you must start with the medicine.
Absolutely.
If you don't have any organ damage and the BP is high, then what is a cutoff to try with lifestyle vis-a-vis start medicine?
See, the Commission for Hypertension says above 130 you start off with medications.
Okay.
But quite often, if you're in that borderline area and you're obese and you lose weight, you may never require medication at all. So give it 3 months or so. Keep your BP under monitoring. If it's not going up, if it's going down, and you're able to get adequate amount of exercise and you're able to lose, say, maybe even 10% of body weight, you may not require medication.
Right. And then, Dr. Mukherjee, if that is the reason, and you mentioned lifestyle being the first port of call, we see a lot of athletes and people who are really fit, right, also have hypertension.
Absolutely,
Why does that happen?
because hypertension has a genetic component to it.
Okay.
So it is not just environmental and lifestyle. You may have two people following exactly the same lifestyle. One becomes hypertensive, the other doesn't.
Even if they have the same weight and make body
Yes,
weight.
absolutely.
Got it.
So their parents may be hypertensive. There are genetic components to it. So
Right.
it's not a very simple thing.
Got it. And in your practice, what percentage of kidney disease is related to high BP?
30 to 40%.
30 to 40% is related to high BP.
Absolutely. And
Got
if you take it with diabetes, over 60%.
Mm-hmm. And you mentioned 10 to 20% of kids or adolescents are walking in with high BP, right? So, what is sort of the difference in the root causes? Because they're not working, they're not as stressed, probably
Yeah.
about exams.
Yeah, well, see, in children, there are many factors which are called secondary causes of hypertension. They are not primary hypertension or what is called essential hypertension in layman terms.
Right.
Then you have to look for secondary causes of hypertension. For example, hyperthyroidism or hypothyroidism. Then many congenital diseases or things called kakut, which are abnormalities of the kidney and urinary tract. He may be having a solitary kidney or a horseshoe kidney or ectopia of the kidney. Then people have tumors like pheochromocytomas. So when you have very young hypertensives, you have to look for secondary causes of hypertension.
So, you're saying kidney disease can be a cause for high BP in kids?
Kidney disease is always a cause of hypertension. If you have kidney disease, you are going to get hypertension and you are going to have poorly controlled hypertension, irrespective of age.
So, Dr. Mukherjee, now just talking about hypertension or high BP in kids, you mentioned earlier 10 to 20% of people, kids walking in, have high BP. What is the normal cutoff for them? And if diagnosed, what is the further workup?
Yeah. So for children, around a systolic of 110 to 120 is normal. Anything above that is abnormal. For when you have young hypertensive kids, teenagers, you have to look for an underlying condition causing hypertension. Either the commonest cause would be renal conditions. They will have a single kidney or a renal artery stenosis, or maybe a kidney in the abnormal, what is called ectopic kidney, agenesis. Then there are conditions which affect the thyroid, hypothyroidism, hyperthyroidism. Tumors of the adrenaline gland, which produces extra adrenaline, pheochromocytomas. So you have to look for all these secondary causes of hypertension. Primary cause is taken as a given only in your 30s and 40s. When you have hypertension in the extreme ages, say you get hypertensive in your 70s, that's not normal. And when you have very young hypertensive with children who are 10, 12, 13, 14, then you have to look for these causes.
Got it. And in case of kids or adults, either, there is a thinking that the upper reading or the lower reading, systolic, diastolic, it's more alarming. Like people think that diastolic reading is more of a sign of heart damage than systolic. Is any of that true?
No, not really. Hypertension, the systolic and diastolic are more or less married to each other. They go up. You don't have upper part going up and the lower part going down, right?
Okay.
So for diagnosis, it's usually when we give the grades of hypertension, it goes by the systolic, but the diastolic will go up with the systolic.
Right. So, Dr. Mukherjee, in our work, we also see a number of cases with hypertensive crisis, like BP above 180 by 120.
Yes.
Some may be isolated, some may actually be telling something. So, if someone measures their BP in whatever setting and whatever time of day, and it is above 180 by 120, either of the two readings, what is the immediate step they must take?
Go to a hospital, get admitted. That is the first thing.
Okay.
Any reading which is 180 and above is dangerous. It's going to cause problems. Problems in the sense it can cause an intracranial bleed. Brain damage cannot be recovered from. Why would you like to risk yourself for that? So one is that. Second is there are conditions called dissections of the aorta, where the lining of the aorta like a banana peel peels off. Kidney failure. These are very common side
Because the
effects.
blood is flowing with such pressure.
Absolutely. It's like a high pressure hose. It causes damage. And when you're trying to reduce the blood pressure, it has to be brought down in a controlled manner, in a controlled environment, which is the intensive care unit. So if you have a BP above 180, please get admitted, get your BP under control, go home. There's
Right.
no problem. But in my practice, anyone above 180, I'm very insistent they should get admitted.
And anything which is borderline, like 170 by 110.
Borderline, it will depend. If you have a proximate cause, the patient has been traveling from outstation, he has missed a tablet, right? Then yes, you can say, okay, go take your additional tablet and just watch. How sincere is the patient in their monitoring? If I have a freshly diagnosed hypertension with a BP 170, maybe after 2 hours it'd be 190. So I would be very uncomfortable sending such a patient back just on medication.
So your cutoff is more like 160 by
170 and above, I would always say, keep
Go
in
to
the
the
hospital,
hospital.
get it under control and go.
And then
Unless, as I said, that I have a very specific cause.
got
He
it.
says, like, oh, I was on the train, I missed my morning dose.
Right, right. And then in the hospital, they would of course give the drugs,
First
probably
intravenous,
injectables.
get the blood pressure down, then switch over to oral medication, stabilize the blood pressure, and then we say.
And they may do some checks for your ECG,
Absolutely.
EEG.
We look for target organ damage, we look for proximate causes.
Right. Got it. And in such a case of hypertensive crisis, Dr. Mukherjee, are there symptoms, or even here it may be asymptomatic?
Symptoms may be there. Some people complain of blurring of vision. Some people have seizures, epileptic seizures. Some people get palpitations or arrhythmias. Some people may get bleeding in the urine,
Right.
but majority still remain asymptomatic.
Got it. And you spoke a lot about, target organ damage because of high BP. Now, for a patient who has certain organ impacted, beyond controlling BP with medicines and lifestyle, what are the different interventions, for example, for kidney disease, right? They say there's not much treatment apart from controlling the root cause, or for the eyes or for the heart. What are the other treatments people must consider?
See, first part, what you correctly said is get the blood pressure under control. Then, when you have kidney disease, you have specific medications which need to address the problems which are there when you have kidney disease. For example, your hemoglobin will fall because the hormone erythropoietin is made in the kidney.
Right.
So you'll have to supplement that. You'll have to supplement iron. Patients, the kidney is the one that neutralizes acid in the body, in the blood. If kidneys are not working, you'll be acidotic. So that has to be, so you'll have to give tablets like soda bicarb to correct that. Correct. So those supplements will depend on what are the abnormalities you note.
Right. But correction of kidney disease is probably more difficult.
There is no medication in the world which repairs kidney damage. You can only prevent it, slow down the progression, but acute damage can be reversed.
Okay.
So if you have a thing like acute tubular necrosis, which has happened because of hypertension,
Short-term kidney damage.
that will come back.
Okay. Got it. And have you seen any advances, like people are talking about stem cell technology and many other robotic surgeries which help you revive kidneys?
Okay. Stem cell is still in a very nascent stage. As of now, there is no proven stem cell therapy for any condition almost. There are isolated reports of it working in a very controlled environment in a lab, but no large scale application as of now. Look at it this way, we are not even able to grow hair. How will we grow a kidney? Now, surgical intervention for kidney disease is there because you have very specific causes. Suppose you have a narrowing of the renal artery, which is impeding the blood supply to the kidney. So you put a stent in, you improve the blood supply, and you may revert the kidney damage. Or you have a stone which is obstructing the flow of urine. Remove the stone, the swelling goes down, the hydronephrosis goes down, the kidney damage gets reversed. But they are in specific context.
Right. But it's not like you can just, repair high creatinine through any medicine.
So kidney damage is of two types. One is an acute damage and one is a chronic damage. To explain by giving examples, if you fracture your leg, it will the bones will reunite and you'll walk again. If your leg gets amputated, there's no way you can attach that leg again.
Right.
So chronic damage is like an amputation,
Got it.
while an acute damage is like a fracture. Or to put it another way, if you have a haircut, the hair will grow again. But if you're bald because of age or some other factor, no matter how much of oil you put, you're not going to grow your hair again.
Got it. And in terms of creatinine as a report in the kidney test, which I think most of the people know now, there's enough awareness. What is the cutoff of, something being alarming?
Okay, one of the most important thing is that why do we measure creatinine? Okay, creatinine is not a toxin.
Yeah, it's unfortunately made a villain.
No, it is not. The problem is that all the toxins are so expensive to measure that if you have to do renal function assessment, doing them, it will cost you tens of thousands of rupees.
Okay.
So you can't. So we have taken a marker which goes up when kidney gets damaged, say creatinine or cystatin C, and we use it as a surrogate marker for kidney failure. Correct. The problem with creatinine is creatinine will only go up when you have already lost 50% of kidney function.
Wow.
So, suppose you have started with 10 fingers, when you have already lost 5 fingers, that is the time your creatinine will first go up. So, there is no early diagnosis of kidney disease using creatinine. Creatinine, when it has gone up, you have already gone into kidney damage.
So, what is an early sign of kidney damage?
Proteinuria. Leakage of protein in urine, the cheapest and the easiest test to do. Pass urine, painless, one dipstick, 50 rupee cost. And that is the most neglected
115 cities, but yes, so you're saying routine urine test, what we call urine
Urine
microscopy.
microscopy.
So that is the sure shot way of catching
That is
early
the
kidney.
first sign of kidney damage.
And if someone finds blood in urine, is what you're saying?
Protein in urine.
Protein in urine. So sorry.
Blood in urine is always abnormal.
Right. So that of course has to be worked up in different ways.
Correct.
But if someone finds protein in urine, what is the further workup, or till what level then?
Yeah, so when you have protein in urine, then you do a kidney function test. You look at your urea, creatinine, calcium, phosphate, sodium, potassium. You look into your parathyroid hormone levels. You look into your hemoglobin, iron levels. You do an ultrasound and look for what is the appearance of the kidney. If you want to measure the kidney function, there are tests called GFR, glomerular filtration rate, DTPS scans that actually measure. If you have a normal kidney size, then the doctor may advise you to undergo kidney biopsy, because that is the sure shot method of diagnosing, do you have kidney damage, how much of your kidney is damaged, and what is the cause.
Got it. So that doesn't mean that they're suspecting cancer. They're just...
No, cancer of the kidney almost never requires a biopsy. Actually, biopsy of a kidney is done to diagnose everything but cancer.
Right. I asked because biopsy is mentally correlated
90%
with cancer.
of my patients get palpitations when the moment I tell them biopsy. They think that I'm suspecting cancer, but that's not the case.
And given we spoke about kidney cancer, Dr. Mukherjee, I've in fact had a case of a very young family member who was accidentally, diagnosed with RCC or kidney cancer. And these cases are extremely common. I think India is one of the countries with very common.
We have bladder cancers and kidney cancers.
Right.
Like what you said is renal cell carcinoma. It's very common.
Very common, and they don't get diagnosed.
Yeah, they get diagnosed late again because they are painless. So either they are diagnosed because of an incidental ultrasound, or he has got bleeding in urine.
Okay, so a urine test and ultrasound, for example, if someone is doing regularly, these things can be kept in check.
Correct.
Got it. Now, just talking about the root causes of hypertension, I'm going back to the root cause, Dr. Mukherjee, and you spoke about salt, right? Which again is unfortunately a big villain in our lives. No one knows how much to consume, and while we think we are just taking so much, we are taking these processed foods which are full of sodium. So, what is your theory on salt? What do you guide your patients on?
Okay. And average salt requirement. See, salt is an essential equipment. Your brain requires sodium to function. Your bone health requires sodium. Bone is more than calcium and phosphate. There's a third element to it, sodium. So when sodium goes down, you're prone to fractures. So it's not a villain. It is an essential component to body functioning. But the requirement is limited. If you see at one time, the word salary comes from salt. Roman soldiers used to be paid in salt.
Oh, okay.
Okay. So salt was, because wars used to be fought over salt.
Like now, oil.
Yeah, anyone who controlled the salt mine controlled trade. So salt is very essential, but salt was never really available very easily in the olden days. You have to go to the sea or to rock basins, get the salt, take it out. That's why it was a very precious commodity. Now salt is very easily available, so we tend to overuse it. Approximate requirement is 3 to 5 grams, but that doesn't make sense to anyone. I mean, you tell somebody take 5 grams of salt, he'll look at you, what are you talking? How do I know how much of salt to take? So the broad spectrum which we tell people is that add the amount of salt you require to taste while cooking. Don't add salt on the table. That itself cuts down on unnecessary salt.
And pickles and chutneys.
Pickles, chutneys, chips, fried stuffs, papad, they are very high in salt. Preserved foods, preserved fish, because you use salt as a preservative.
And the bright packaged foods.
Absolutely.
Namkeens in India.
Absolutely. Pizzas. So those, if you can avoid, you will have a normal salt intake. Avoid soft drinks again.
And what about breads and bakery?
Yes, roti is safe. Breads and all are very high in salt, especially packaged breads. While if you go to bakery baked breads where you get fresh breads, the salt quantity is far lesser.
So basically anything which comes in a packet will be high in salt.
Yeah. The other problem of salt is salt fats. Senda namak, kala namak, Himalayan salt, pink salt, grey salt, black salt. None of it is very good for you.
Because it doesn't have iodine.
No, not just have iodine. It doesn't reduce your salt load. It gives you an extremely high potassium load.
Okay. Can you talk about that a little bit more, Dr. Mukherjee?
Yeah, all these salt supplements. Say you say some lights, Tata Light. What does that mean? You replace the sodium with the potassium. So it's not really great. But just control the amount of salt you take. You don't have to have fancy salt.
Right. And salt comes from the ocean, so the natural salt.
Yeah, and
purified.
all this pink, yellow, green, blue, black, they are of no use.
So normal salt is the best salt.
Normal salt, approximate amount which you're cooking, take that much.
Avoid packaged food and bakery products.
Correct.
And pickles and chutneys in
Correct.
India.
Absolutely.
Got it. Also wanted to talk about one more sort of root cause we often ignore, which is sleep, Dr. Mukherjee, right? And we're all living in the world of insomnia where there's OTT, there's distraction, there are pings and there are notifications and there's self-image pressure on Instagram, right? So do you think sleep has a role to play in high BP overall health?
Absolutely it does. You have, in fact, at one time, if you remember, the first thing the doctor used to give you when you go with hypertension is take the sleep tablet, sleep well for 1 week and then come back to me. So sleep has two parts. One is the stress and the OTT and the screen times. Second is a condition called obstructive sleep apnea, where people are obese and they snore and they don't sleep well. Though that is also a proximate cause of hypertension. You control obesity and obstructive sleep apnea, your hypertension gets corrected.
So what's a good sleep ritual? What do you guide people on when they come and you feel sleep is a root cause of their diseases?
Sleep well in time. Have your dinner by 8 o'clock. Sleep by 9:30. Get up by 6. Very difficult to do because by the time you come back from office and you're catching up on your media only at night and you're watching your serials only at night, that causes a problem.
So I'm just very curious, given your very clear concepts and so interesting, Dr. Mukherjee. What are the mantras you follow in your life for your health or your family?
So, okay. As far as I am concerned, I am little social media retarded. I'm not very much into social media, not because I think it's evil. I think it's very good and it's an essential component of our life. We have to learn to live with it. I'm not very active on it, and I tend to sleep off by 10, 10:30, 11, unless some specific I'm on a call or some patient is very sick, and then I'm up by 6. Earlier, I used to be very active. I used to love cycling.
Mm-hmm.
Cycling in Gurgaon is very dangerous,
Right. Extremely.
so I don't get to do that very much. When I was in Delhi, I used to cycle up to India Gate. I used to love doing
Oh,
it.
wow.
Nowadays, I don't cycle on this thing. When I get time, maybe once or twice a week, I go to the gym and do a stationary cycle, which is just not the same.
Very good to hear, because often I get to know that doctors don't get time for their own health, right?
No,
They're
it is not just time. It is an inclination. By the time you're back home at 6:30, no, you tend to uh, behave like a sack of potatoes. You want to just lie down on the couch and not do
no, that's true for
anything.
all professions,
Yeah,
not just
so
medicine.
we tend to give excuses to ourselves,
Right.
but that's
Thank you
what.
so much, Dr. Mukherjee. Any last bit of knowledge you want to share with our audience, or any story you would like to share from your practice?
First, I would like to compliment organizations like you. You know, when people come to hospital, that's sick care.
Mm-hmm.
That's not health care. Health care is before you fall sick, and you guys are doing a great job.
Thank you so
So
much,
I'm quite
doctor.
impressed. When you manage to convince even 10 people that change your lifestyle slightly and they become better. I've seen it work wonders. I've
Mm-hmm.
seen patients come with kidney disease, and after 2 years of doing it, stopping smoking, stopping his marijuana, stopping alcohol, and he goes for a squash and his creatinine is normal, is very heartening
Mm-hmm.
to see. Um, Specifically, I find that the relationship between a doctor and a patient, or a healthcare worker and a patient, if it's a very healthy one, everyone benefits.
Mm-hmm.
The patient listens to the doctor pays attention to the benefit of the patient. If we can maintain that, I think we'll have a great system.
Wow, so well said. And coming from you after 3 decades of experience, Dr. Mukherjee, it was a pleasure hosting you, learning from you. Thank you so much for answering my questions patiently. And to our amazing audience, I hope you learned a lot from Dr. Mukherjee just like I did. We'll see you on the next episode. Until then, take care of your health and take care of your BP. Bye bye.